Hello and welcome back for another episode of PodcastDX, the show that brings you interviews with people just like you whose lives were forever changed by a medical diagnosis. I'm Lita.
I'm Ron.
And I'm Jean Marie.
Collectively, we're the hosts of PodcastDX. On today's show, we are speaking with Kitt.
Kitt is licensed in California as a marriage and family therapist. She has a bachelor's degree in legal studies from UC Berkeley, a master's degree in psychology from New College of California, and attended Fuller Theological Seminary.
Oh, wow.
Yeah, wow.
Kitt is joining us. That's quite a repertoire there. Mm-hmm. Kitt is joining us today to speak about mental health, specifically bipolar disorder.
Yes, thank you. Thank you for inviting me on PodcastDX, and thank you too for your mission, PodcastDX's mission, to interview people living with a diagnosis. Hearing from others who have gone through the same struggles helps us feel less alone, and it provides insight based on our experience. And now I'm a strong believer in mutual support because it goes a long way. Many of us living with mental illness like bipolar disorder, which I have, feel alone and misunderstood. When someone else describes their experience, we feel understood and see that if others can live full, meaningful lives, so can we.
Absolutely.
That's amazing. Yes, absolutely. That might be our new description on our website.
Yeah, we're gonna have to listen to that again.
Yes, you covered all the bases. Well, thank you for joining us today. We really appreciate you taking the time, Kitt. Could you start us off actually with an explanation of what exactly bipolar disorder is?
You bet. Bipolar disorder is a serious mental illness. It's also abbreviated as SMI for serious mental illness that can deeply affect one's life. Now, according to the National Institute for Health, bipolar, which is also or previously known as manic depressive illness, which is more, to me, more descriptive and accurate, is a brain disorder that causes unusual shifts in mood, energy, activity levels, and the ability to carry out day-to-day tasks. Now, the current Diagnostic and Statistical Manual of Mental Disorders, or DSM-5, includes 4 categories of bipolar disorder depending on symptoms and severity.
Okay.
So could you tell us a little bit more about those 4 types of bipolar?
You bet. Sure, again, I'm citing the National Institute for Health and the DSM-5. So bipolar disorder 1, or type 1, is defined by manic episodes that last at least 7 days, or by manic symptoms that are so severe that the person needs immediate hospital care, immediate psychiatric hospital care. Usually depressive episodes occur as well, typically lasting at least 2 weeks. Bipolar type 1 can include a variety of specifiers or specific features, which can include anxious distress, mixed features, that's when you have both the depression and the mania at the same time, rapid cycling, which means rather than it going for the 7 days or 2 weeks, it cycles more frequently, melancholic features, which would be sort of depressive features, atypical features, which don't fit into the others, and then mood congruent psychotic features, which would be psychosis that your ego doesn't disagree with, like you believe it, and mood incongruent, or it says mood, so maybe mood has to do with it doesn't hit mood. Mood incongruent psychotic features. I know when I had experienced psychotic features in the past, I knew it wasn't me. I knew it was something else. Mm-hmm. Catatonia and peripartum onset. That's onset caused by the hormonal changes of pregnancy and post-pregnancy. Now, bipolar 2, which is the second type, has a pattern of depressive episodes and hypomanic episodes. So it doesn't have the full-blown mania. Hypomania is less than mania. So if you look at it in a spectrum, it's sort of mania-like. It's a distinct period of abnormally and persistent elevated, expansive, or irritable mood, and abnormally and persistently increased activity or energy lasting at least 4 days consecutive and present most of the day, nearly every day. The third type is called cyclothymia or cyclothymic disorder, and it's defined by numerous periods of hypomanic symptoms as well as numerous periods of depressive symptoms, and it lasts for at least 2 years. or 1 year in children or adolescents. Now, the symptoms of cyclothymia do not meet the diagnostic requirements for hypomanic episode or depressive episode. So you go from severe 1, less severe 2, to what they also know as bipolar 3, cyclothymic, which is even yet less severe. Now, there's a 4th category that's sort of which in bipolar 4 they called not otherwise specified, but in bipolar 5 they got into more specifics, sort of like types that don't fit into the categories I just told you. And those would include bipolar and related disorders induced by certain drugs, even medications, like an antidepressant can trigger bipolar, or alcohol due to a medical condition like Cushing's disease or multiple sclerosis or stroke. Okay. So all of those things that can affect or damage the brain can also bring about triggering a bipolar disorder. Okay. Now, before I received a bipolar diagnosis, I was diagnosed with major depression when I was 18, then dysthymia, which is known as chronic depression, as my severe depression lessened, but the depressed mood and thought process continued. Then at 39, I was diagnosed with, that's like over a decade after the 18-year-old diagnosis, I was diagnosed with bipolar type 2, and upon my hospitalization at age 42, my diagnosis became bipolar type 1, even though I held on to that diagnosis of bipolar type 2 in spite of the fact that I was unable to return to work and qualified for SSDI. So up until recently, I identified myself as bipolar type 2. It was partly internal stigma that I held on to that.
Sure.
Even though I fit the criteria for type 1.
Okay.
I understand that you're a licensed therapist, and as you mentioned, you also live with bipolar disorder. How has your education affected how you view your own mental health? And did you pursue a degree in mental health because of your own personal experiences?
Those are great questions. Honestly, yes, but I applied to grad school by what I call serendipity. So unlike my undergraduate, I feel like there's like things happened in my life and it just all sort of happened. Unlike my undergraduate education, which was focused and goal-oriented, my choice to study psychology sort of just happened to me. After I graduated from UC Berkeley as a legal studies major, I worked as a legal assistant to see if I wanted to pursue law, And then after 2 years of being a workaholic legal assistant, I took time off because I was like, okay, there's no way I can lead a balanced life doing that. And during that time, my time off, which is a few months, I attended a lecture at a law school and I participated in their discussion. Afterwards, the dean of the law school asked me if I was interested in attending law school. I said no. Then right beside him was the psychology program's recruiter, and she said, well, would you be interested in studying psychology? And she pitched their program. It sounded interesting. I applied, ended up getting a master's in psychology, and got my license. It used to be called Marriage and Family Child Counselor. Now it's called MFT, a Marriage and Family Therapist. And although I don't practice psychotherapy now, I stopped when I was 30 and I'm 56 now. I still hold on to it and keep it active by doing the continuing education. That I found the program interesting and that it spoke to me, no doubt was part and due with my experience with severe and moderate depression.
Sure. I could understand that. How long did it take for you to get your proper diagnosis yourself?
Yeah, well, as I mentioned, I was diagnosed bipolar when I was 39, and even though I had had symptoms of bipolar disorder before that, for 2 decades, since I was suicidal at 18, I lived with the diagnosis of dysthymia, which is known as chronic persistent depression. And my depressive symptoms under dysthymia included being very sad, down, hopeless, and suicidal in terms of ideation, but not in terms of action. So it was just thoughts. And then at 30, I turned to medication to manage my depression because it was very severe. I couldn't even get out of bed. It was horrible. And the antidepressants that I took then led to a psychotic manic episode. So that's sort of like that not otherwise specified bipolar,
Right,
and it makes
right.
things
Based on the
difficult to
medication.
diagnose.
Right, right.
Because it was because of the medication that I became manic. So I was unable to sleep for a full week, and I had simultaneous, rapid, streaming thoughts about the mystic saints, all those saints in Roman Catholicism, and all those. Anyway, Christian mystic saints, chaos theory, which is a branch of mathematics of which I was unfamiliar, and in binary, which was like a whole stream of ones and zeros going through my head.
Oh.
Now, yeah, it was pretty interesting, actually. I knew it wasn't me. I knew it was psychosis, but I was fascinated by it. The clinician in me was like, the intellect in me was like, oh, this is interesting.
Yeah.
I'd even wished I could take it and then later on decipher it to see if it made sense. Because it was happening so fast, I couldn't even understand what was going on. So, unlike my depressive symptoms, I experienced the extreme up, elated, euphoric, and energized behavior known as manic symptom episodes, and then less severe manic periods are known as hypomanic episodes. So though I had experienced those symptoms of mania, my psychiatrist believed that my symptoms were what's called iatrogenic, or caused by medical treatment, specifically a reaction to the antidepressants that I was prescribed.
Okay.
Go ahead.
Well, I was kind of curious. So is it fair to say that initially you just suffered from depression, and the medication that you were taking for the depression changed your diagnosis to bipolar, or
exacerbated it?
Or did it just increase it where it was able to be diagnosed?
Right. Well, here's the thing that's interesting. Like, the people who knew me when I was going through that episode were shocked that I wasn't diagnosed bipolar at that time.
Okay.
But my psychiatrist believed it was just triggered by the medications and stabilized me, on a low dose of antidepressants, which was slowly titrated up. Every time my thoughts would race, I'd call them up, say my thoughts are racing. Okay, now take a half a pill or every other. You know what I mean? Like, reduce it slowly built up. So I could have been diagnosed bipolar back then, I think.
Okay.
But I wasn't. At that point in time, that was a long time ago, they didn't even have bipolar type 2 in the DSM. And when they interviewed me about my past behavior and my past stuff, nothing fit into a bipolar type 1 diagnosis. It was just that week of mania. Okay. But looking back, I can say, I was hypomanic all the time. I was a total workaholic. And then I would crash because you can't sustain that. Mm-hmm. But it wasn't until I was 39 that I got the diagnosis. So what happened was I started getting euphoric symptoms that reminded me of the manic episode I had when I was 30. I started thinking, God's calling me to go. It wasn't bad things. It was like God's calling me to go to Bible study here, and God's calling me to go to church and spiritual direction at this other church. So the things themselves weren't bad, but that euphoric feeling and that feeling that God was calling me made me realize that I was becoming manic. Okay. And so, and at that point, I was diagnosed bipolar.
Okay. Do you think that that's typical for somebody with bipolar as far as diagnosis? The way somebody goes about getting diagnosed, is that a typical course?
Yes, I think so. It's very difficult to diagnose bipolar disorder because people usually present with depressive symptoms. Mm-hmm. And they don't always present with a lot of people who experience mania, they don't think of that as a problem, but they think of the depression as a problem.
Right, mm-hmm. right.
So because it's sort of unless you have somebody observing your behavior sort of around the clock every day, you're not really getting an accurate picture of that person. Mm-hmm. Like when I was hospitalized, they were able to see my behavior every day for 2 weeks in the hospital and for months of what's called partial hospitalization. So they were able to see me more accurately than going to a psychiatrist every few months.
Sure. That makes sense.
So, Kitt, how is bipolar disorder typically treated? Now, I'm assuming that every case is different, but is there anything in common?
Yes, there's it's usually it's a lifelong condition.
Mm-hmm.
So treatment is directed at managing the symptoms, and depending on your needs, different people have different needs. But treatment would include, I'd say my personal observation is that if you have bipolar type 1 or 2, you've got to be on medications. So often you'll need to start taking them to balance your mood right away. And for me, it's made a world of difference, medications. Now, continued treatment, bipolar requires lifelong treatment with medications, even during periods when you feel better. And that's where people get in trouble. Like the medication starts to work, they feel better, and so they go, oh, I'm doing fine now, and they stop taking it. And then they relapse. And what would be a minor mood change turns into a full-blown mania or depression. Now, another way of treating it is day treatment. I just mentioned that I was in a partial hospitalized program, and what that was, I go into the hospital in the morning after my 2 weeks inpatient. In the morning, I'd be in groups all day until it was like basically a work day of doing therapy every day for months, and, group therapy. And these types of programs, whether like that, which was run by a hospital with clinicians, or whether it's going to other types of day treatment where it's maybe more open-ended and not involve hospitalization, they help to provide structure, and that structure helps you to stabilize. Now, many people with bipolar disorder have what's called co-occurring substance abuse, because they use the substance, like alcohol or drugs, to manage their symptoms. So if you have any problems with alcohol or illicit drugs or recreational drugs, you'll also need substance abuse treatment. And otherwise, it's really hard to treat the bipolar disorder. Now, if it's very severe, you may need hospitalization. Many people with bipolar type 1 have at least one hospitalization. And you definitely need it if you're behaving dangerously, if you feel suicidal, or if you become detached from reality or psychotic. Now, getting psychiatric treatment at a hospital can help keep you calm, safe, and stabilize your mood, whether you're having a manic or a depressive episode. Now, I had myself voluntarily hospitalized when I was unable to maintain stability, and at that time it turned out that I was experiencing mixed symptoms and rapid cycling. And I was very lucky to have access to an excellent inpatient program. Not all hospitals are equal. We definitely, as a country, need to improve our psychiatric, first of all, increase the psychiatric beds that are available and improve the quality of care there. My psychologist at the time said, you go to this hospital, it's the best hospital, around. And I even had a view of the ocean from my hospital.
Oh, nice.
Beautiful.
That can be therapeutic.
I love that therapy,
wow,
right?
Yeah.
It was like, yeah, I'll take this any day. So it was a great program. So the primary, I'm just reiterating that the primary treatments of bipolar are medication, psychotherapy, counseling, and then both those help control the moods, and then you also need education and support. You need to understand what your illness is. Same with family members, and also participate in support groups. That can be very helpful.
Okay.
And then the education and support that I received at NAMI, they have a peer-to-peer class, the National Alliance of Mental Illness, and that peer-to-peer class made the difference for me. So here I'm taking a peer-to-peer class. I don't remember how old I was, in my 40s, and I had been first diagnosed depressed at 18. It took me a long time to get there, but it introduced me to the concept of mental health recovery, which gave me hope. When I first was diagnosed, I thought, oh no, I have a chronic, severe, degenerative, progressive psychiatric illness. I'm going to be a bad mom. I put my kid in daycare. It was self-stigma. So that program helped me kind of overcome that internalized stigma.
Well, that's great.
Yeah, that had to have been a big step.
Jean said that we recently took a mental health first aid course, and she was wondering she said the reason they think that's important is that there's a greater tendency of running across somebody that has a mental health crisis in
your day-to-day life.
In day-to-day life than somebody that is having a heart attack and needs CPR. And
right.
we were just wondering what you thought about the new mental health first aid courses.
I think I haven't taken it, but I know people who've taken it, and it's great. Educating the public is very important. That type of thing is also really one of the ideal places to have it is in churches and things like that, because often people go to their church before they go to their doctor,
right?
When they're experiencing mental health symptoms, and so they tend to be first responders.
Right.
So for both any kind of first responder or family member, or even just in the community, the more education there is and the more skills people have, the better.
Okay, good.
It's not just individuals. That's the thing that
exactly.
A lot of people think.
Like I was saying, maybe Girl Scout leaders or Boy Scout leaders.
Exactly. That's awesome. In fact, I trained as an EMT and volunteered. I was super high achiever.
I was going to say, I don't know if there's anything you haven't done.
But definitely that education's invaluable.
Okay.
And the more people who know, the better. And that's one thing is that sometimes people think when they have a mental illness, it's just an individual choice whether or not to participate in treatment, to take their meds or to go to therapy. But it's not just an individual choice, because everybody in the world is affected by mental health issues. Because if you don't have mental health, you might know somebody who does. If you have 1 out of 5 people who has a serious mental illness, that means that it's touching everybody's lives.
Exactly.
Certainly. So my question then is, somebody that has, for example, bipolar disorder, what can they do to help themselves?
Okay. Well, let me see where definitely they can keep an open line of communication with their psychiatrist and their therapist, and hopefully have the two communicating with each other, like having releases so they can talk to each other. So your therapist and your psychiatrist. Also involving your family. Often my husband will notice that I'm hypomanic before I notice. He'll say, "Have you noticed you're talking really fast? Have you noticed you're being really irritable?" And just his little gentle reminders make me realize,
okay,
I better address that in therapy and with my psychiatrist. Like even recently, I noticed that I tend to be, because I've been in therapy so long, I tend to be more insightful. And I'm not boasting, but the more therapy you do, the better you know yourself.
Sure.
Which is a good thing.
Yes. So recently I started, I'm publishing a book, and once I started, as soon as I sent it into the publisher, I started to ramp up. So, and I realized when the hypomania lasted like over a week, 2 weeks, going on 3 weeks, I went into my psychiatrist. I called for to get in for a canceled appointment as soon as possible. And I said, "This is not, I'm worried." And so he added medication. It made all the world of difference to me.
Mm-hmm.
So is a lot of it just being open and honest with yourself?
Yes. And psychoeducation helps there. It's not only therapy, but like that class I told you about, there are classes, like you're talking about the crisis. I forgot already. It was the problem part of the meds in me. Mm-hmm. The crisis intervention treatment, or whatever you call it. I forgot. The first aid.
Mental health first aid, right.
Right. That class is lots of psychoeducational programs that are offered by organizations, whether it be the National Alliance on Mental Illness or whether it be DBSA, which is so we have NAMI on the one side, or DBSA, which is the Depression and Bipolar Support Alliance. So those sort of organizations offer psychoeducational classes for both people who have mental health diagnoses, which they call now person in recovery. Anyway,
sure.
And also they offer family support.
Okay.
Because the family is huge part of being, being a support to the person. And they need their own support because it's not easy.
Right.
Usually loving someone or caring for someone
Right.
with a severe mental illness.
Caregiver support,
So
sure.
I'm a big supporter of psychoeducation.
Okay. And you mentioned that it's important to form interpersonal relationships. What role have your family and friends played in your mental health care then?
Support is 100% important. In fact, when I had my psychotic break, I didn't go back doing, that's when I ended being a psychotherapist, basically, because I was like, whoa, I need to take care of this.
Mm-hmm.
And I ended up moving back in with my parents, and I needed that. And they were incredibly supportive, like unbelievably supportive. And that helped me get back up on my feet, go in, take a temp job once I was well enough to work. And then that kind of grew into a career in real estate, actually commercial real estate. But I wouldn't have been able to do that if it weren't for my parents.
Well, that's great.
And my husband is a big support. And I'm involved in my community in terms of my volunteering. I know people in the community. I tend to isolate, but I still, when I go out to do a training or something for NAMI, like the provider education training,
mm-hmm.
I know people. And what I do, which is easiest for me, is I get a lot of support online.
Okay.
I'm part of a huge support network online.
Right.
Good.
Yeah, we have definitely used online services more than once because you go to a doctor's office and they only give you so many minutes out of their day.
Right.
So it's good to kind of build your repertoire of questions before you even go in now.
Right.
Could you tell us what is a good day for someone with bipolar compared to a challenging day?
Okay, for me, a good day could be like I took a bath. I mean, it's true that sometimes the real small things can make a real big difference. So a good day could be I took a bath, or I did a good amount of work on the computer, not too much. Like I wasn't.
Right, you didn't overdo it. Right.
I went to bed at a reasonable hour, and I took my medicine. Those are all good days.
Okay.
Bad day would be when my thing that is, I seem to be in this stage of my illness. I've had different symptoms predominate during different stages. Earlier on in my life, the depression dominated. And now the hypomania dominates, or at least it's what I'm most concerned about because I don't want to be hospitalized again.
Mm-hmm.
And I want to be a good mom and a good wife.
Mm-hmm.
Mm-hmm.
So some of the workaholism I did in my youth might be okay for a single person to do, to keep on, shooting high and crashing. But now I can't do that because my symptoms affect my relationships and I don't want to rage at my son, for example,
Sure.
or be irritable with my husband when they haven't done anything. Even if they hadn't done something, it just is not okay to do that. I don't want. So a bad day would be me throwing what I call an adult temper tantrum.
Okay.
So, once I even flipped the table, and once I threw my iPad on the ground. That to me is an adult temper tantrum.
Sure.
And that would be a bad day.
Okay. Thank you.
But usually I can pull it together. I can look at myself and I go, what did I just do? Oops.
Right. Kind of take a step back, take a deep breath, and start over.
Yeah.
Right. Okay.
Right.
Thank you.
Kitt, besides having good days or bad days, how does having bipolar disorder affect your day-to-day life?
Well, over the, I used to be like a very outgoing social person, but now social stimulation triggers hypomania, and which then triggers mood cycling. And so I've had to, although this new medication is helping me with the hypomania, which is awesome. So I might be able to go back out and be a social person again. We'll see. So, but over the years, I've had to redefine what success means to me. So once upon a time, I was a straight A student, was supposed to become a doctor, and then was supposed to become a lawyer. You know what I mean? There was these very high expectations of me when I was young. And then when I started to experience mental health illness, symptoms, I knew, okay, I have to rethink this. So now, my redefining success means that I found purpose in my experience. And my purpose I use for mental health advocacy and for writing from my experience, both online and in my book, here's my plug, Balancing Act, Writing Through a Bipolar Life. And I'm also blessed to live at a time when I can titrate or, kind of control my social contact and work at my own pace thanks to the internet.
Okay.
Great. Thank you.
Yeah, that's great. I think I have one last question from Jean. We haven't really talked about the cause of bipolar yet. Do doctors know what causes this to become a part of a person's medical history?
Okay, well, actually, some studies have suggested there may be a genetic component to bipolar disorder, and it's more likely to emerge in a person who has a family member with bipolar. So patients with bipolar disorder also show physical changes in their brains, but the link is unclear. But it's interesting in terms of brain scans. They've also shown that taking the proper medications heals the brain, even an adult brain.
Oh,
not
nice.
that it doesn't get rid of the bipolar disorder, but every episode you have damages the brain.
Okay.
Mm-hmm.
And so in taking medications, you prevent that damage, and also there's some rollback, some healing of the brain. It's still a bipolar brain, so to speak, but it's a healthier bipolar brain.
That's good.
And then then there's brain chemical imbalances, like neurotransmitter imbalances that appear to play a key role in mood disorders, including bipolar disorders, and hormonal imbalances. So can trigger or cause bipolar. I have a good friend who, all of her bipolar symptoms were triggered by a pregnancy.
Okay.
So, and many women have to understand what changes happen to their brain when, like it's not just postpartum, there's postpartum depression, there's postpartum psychosis, there's postpartum bipolar. That's because there's hormonal changes change your brain. And then there's environmental factors like abuse, mental stress, significant loss, or some other traumatic event can either contribute to or trigger a bipolar disorder.
Okay.
And it's possible that those with a predisposition with bipolar may not have noticeable symptoms, like they might already have it.
Right. And then something triggers it and it gets worse.
Factor triggers, yeah.
Right.
Yeah.
Okay. I don't know what area of the country you live in, but are you in an area with good specialists and doctors that will treat bipolar? And besides yourself personally, are there parts of the world that care is not available because we are posted worldwide?
Now, I live in Orange County, California, which is an affluent county.
Okay.
And there's many mental health professionals here. So I have access to great mental health professionals. And there's several medical schools in the greater Los Angeles area, which I'm a part of. So it's an excellent place to find qualified, experienced mental health professionals.
Okay.
But when I lived in the Mojave Desert, it was a couple hours away in the desert, and it's very rural. There are not a lot of people there, and very few mental health and physical health providers. And so we're living in a rural desert community involved driving really far to see a doctor. Mm-hmm. And for anybody in the U.S. living in a rural area, you have less resources than living in an urban, a major urban hub. So, and then, but for me, I'm on Medicare, and because I live in an affluent area, very few therapists and psychiatrists accept Medicare. Luckily, I found one that does, that specializes in seeing seniors, and I'm not a senior yet, but I am on disability, so that gives me Medicare.
Right.
But according to the World Health Organization, mental, neurologic, and substance use disorders are common everywhere in the world, and they affect every community and every age group and all income levels. Mm-hmm. So there's 14% of the global burden of disease is attributed to these serious disorders, and 75% in low-income countries have no access to care, to the treatment that they need.
Wow.
Yeah. So that's just horrible. It's horrible. So, and not only do the developing countries not have the resources, but the U.S. itself, which is incredibly affluent compared to some other countries, lacks mental health, adequate mental health resources. So you have, according to the National Institute of Mental Health, there are 11.2 million adults with serious mental illness in the United States. So the serious would be like schizophrenia, bipolar, those, not like, oh, I'm a little sad my dad died. You know what I mean? It's serious mental illness. Only 66.7% in the United States receive mental health treatment in the past year. And then of the those between 18 and 25%, only 57.4% have treatment. And we are very much, there was a push in our country to remove people from sanitariums, and asylums, and state hospitals. And so what happened with a lot of those people, they're now out on the street, not getting any care.
Right. And like you were saying, the rural areas get the least amount of care, and I would imagine that the bulk of the Americans that are on a lower income will be living in, I'm thinking specifically like people on reservations, Native Americans, without any income. They might have a greater incidence of mental health problems because of the stresses of living like that, and here they don't have the access to the care. It's kind of like a catch-22.
Right, and you were talking also about the deinstitutionalization of the 1970s, which was, that's very hard.
Have you found any online support that could be helpful? Like let's say that there are people in a rural area that they can't access a doctor or a therapist as easily. Are there any online support that can help, or any support groups online that could help?
There are definitely support groups online. Now, I find online support very helpful, and although I'm a member of a whole bunch of the groups on Facebook, I find my support outside of, just sort of organically in terms of my following. But I do get support from responses to whatever I write on my website or Facebook or Twitter. But I think one of the things that's emerging that can be helpful for people in areas where there's less, where they're lacking resources is
telemedicine.
It's so much easier to read it.
Telemedicine?
It's telemedicine, yes, telemedicine. That people can actually see doctors via Skype.
Right.
Mm-hmm.
And other online, sometimes they use, not Skype, but they'll use an encrypted way of doing it.
Sure.
Safer for privacy reasons. And those online therapists and online doctors and psychiatrists can help quite a bit. Usually they need an in-person diagnosis first, and then they can work with that. But there is that. I don't know how many of them accept Medicare. It should be something that is available.
Yeah, I agree.
The VA has that.
Yes, the Veterans Administration has a telemedicine.
Telemedicine.
Yes,
telemedicine. Did I say it wrong?
Yes, they have a telemedicine for psych care too.
Yes, and I think that the VA is part of that, partnering to sort of develop programs that will go beyond the VA, Mm-hmm. But any help that the VA can help with people with PTSD, which could trigger other underlying illnesses, is great.
Yes.
Kitt, I understand that you're not only a patient advocate, you've also written a book to help reduce the stigma of mental health care. Would you like to talk a little bit about that?
I'd love to. My book, which is Balancing Act, Writing Through a Bipolar Life, it's basically, I intended it to offer those who, like me, who live with mental illness and their loved ones, to offer them hope. So, and now, as I'm a therapist who left my career due to my own mental illness, I use both my clinical background and my lived experience to educate the public about mental health and fight stigma against those living with mental health by challenging their stereotypes. Like I'm very open because I know that I challenge people's stereotypes of what somebody with bipolar would quote unquote look like, because it's an invisible illness people don't know. Mm-hmm. They don't know that your neighbor, who's a person perfectly, doesn't look any different than you, has something that they're struggling with. So, and then my writing, just as we discussed the 2 decades it took to get my diagnosis of bipolar disorder, which also kind of involved 2 decades of my brain changing, is that I talk about those two decades in my struggle with bipolar and how it took so long to get a diagnosis, and how, most importantly to me, is how my journey gives me purpose. Now, the title, Writing Through a Bipolar Life, Balancing Act, Writing Through a Bipolar Life, refers to the fact that I'm balanced. Well, first of all, for the writing, that writing is therapeutic and helpful, as are the arts, for people struggling with actually for everybody, but for people struggling with mental illness, very therapeutic. And it's actually been scientifically proven that it is. But it also, the title Balancing Act refers to the fact that I balance living with a bipolar disorder with my work as a mental health advocate and caretaker of my son and parents. My father died last year, but my parents both had dementia. And they're in the facility, but still, I coordinate a lot of the stuff and visit. And my son was a high needs kid with his own diagnoses growing up. He's a wonderful kid, but I first brought him to a therapist when he was 4. So obviously he was a handful.
Mm-hmm. Thank you so much.
Well, when is your book coming out?
Oh, my book's coming out September 19th, so probably it will already be on the market when you post it.
Right.
Interview.
Okay. All right, now we're on.
I'm going to jump back a little bit because you mentioned about the invisible illness, and we were talking off air about this earlier. The difficulty, I work at a facility where I have students with physical disabilities, so most of them use wheelchairs or some type of device to ambulate. We also have another program where we have kids with cognitive impairments, but they're standing, they're walking, they're doing anything like you see a lot of people on the street. And most people, unless you're there in the facility, unless you're there at the program, you don't know that these kids that are standing, ambulating, walking, that they have more difficulties than a lot of my students with the physical disabilities. Again, what you see, you react to, but if you don't see it, you don't think that there's anything wrong.
Mm-hmm. Right. And by mental illness, like those cognitive difficulties, neurologic difficulties, all of and other invisible illnesses, whether it be lupus or other chronic invisible illnesses, because they're invisible, people don't realize what you're going through, and sometimes might misinterpret it as laziness or willfulness when it's when you might be in chronic pain or chronic in my case chronic psychic pain, chronic physical pain, and it's very hard for those of us who have mental health invisible illnesses because others don't see it, so they don't think it's real.
Right.
Absolutely. Just real quick, I have a student who has arthrogryposis and a lot of pain in her joints. She does ambulate, but they wound up getting her a power wheelchair because of the pain that she was having. And there were people saying, well, why is she sitting in a wheelchair? She can walk. But they don't understand the pain that she's going through because of her disability. Mm-hmm. So, I can't thank you enough for joining us today and sharing your story with us. Do you have any other additional tips or advice for our listeners out there?
Well, I would say just find support. Include your family when you go, if you need to. Include a loved one to go with you the first time you go to a psychiatrist, or maybe other times if you want to. Because I'm a big believer in a team treatment. Mm-hmm. So the members of your team, whether they go into the appointments with you or not, you want to somehow engage your family, your closest friends, and your clinical, your clinicians, your mental health providers, so that you're not alone. You have support. You have people who love you, who know what's going on and understand what's going on. So that whole team is super important. And I just wanted to, I don't know if that's enough, if we're done, because I wanted very much to thank you for having me, and I'm honored to be a part of PodcastDX. I read that wrong. I know it is. But PodcastDX is your mission to offer patient-to-patient support and advice about our diagnoses.
Right.
And congratulations on your Wego Health Award.
Oh, thank you.
Thank you.
Thank you.
Best rookie.
Yeah.
That's awesome. I'm
Yeah.
totally congrats.
Yeah, we're stoked. Well, Kitt, thank you again for taking the time to talk with us today. How can we find your book on September 19th? Will it be on Amazon?
It will be on Amazon, and you can also visit my website, kittomalley.com.
Kitt O'Malley, Kitt.
OMALLEY.
Okay, .com. All right.
.com. This is my name,
All right.
kittomalley.com.
And I'm going to I'll have links for that on our website also.
Right, because there will be links from there, and you can go to my Facebook.
Great.
There's social media links on there, and I will, once the book is on the market, right now it's on the front page, a mock-up of it, a description.
Mm-hmm.
But once it's on the market, it will link to where you can buy it on the market. And it won't just be in Amazon, but it definitely will be on there.
Okay, great.
Thank you.
Well, we certainly learned a lot today, and we'll probably have questions after the show is over. You are our first guest discussing mental health care. We have discussed.
Oh, wow.
Yeah, we have discussed probably 60 or 70 different diagnoses of physical care. And after Jean and I took the mental health care first aid class, I can't talk today either. After we took the mental health first aid class, we said, we really have got to include mental health in our show because mental health is just as important as the body.
If not more important.
If not more, right.
Right.
So,
right. And what most people don't understand, I'm sorry for interrupting you.
No,
but what most people don't understand is that mental health conditions are physical health conditions.
Mm-hmm.
Right.
Right. Exactly.
They're not. Yes, it's in your mind, but it's physically in your mind.
Yes. Right. I mean, it's not
an imagined thing.
It's not something that you put a cast on and you wear crutches, but it's just as yes. So thank you for being our first guest, and we will probably ask you to come on the show again after your book comes out.
Yes.
Oh, thank you. I'd love that.
Yes, definitely.
We can't wait to read it.
If our listeners have any questions or comments related to today's show, they can contact us at PodcastDX@yahoo.com, through our website, PodcastDX.com, on Facebook, Twitter, Pinterest, and Instagram.
And if you have a moment to spare, please leave a review wherever you get your podcast. As always, please keep in mind that this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition or treatment and before undertaking a new healthcare regime. And never disregard professional medical advice or delay in seeking it because of something you have heard on this podcast.
Till next week.